Hello everybody, I am Dr. T. Varun Raju from TVR Laparoscopy Center, Madinaguda, Miapur. I am an advanced laparoscopic surgeon, course director for laparoscopic surgery, general surgeons and gynecologists. So today's video lecture would be on total laparoscopic hysterectomy. This is focused on the operative steps only. Regarding the indications, preparation of the patients, selection of the patients, and all those things would be in a different class. So usually I prefer to operate on the patient's left side, and the pelvis is towards the downside, and usually the first trocar is going to be kept at the umbilicus or above the umbilicus, and it can be done with a triangulation with 2 secondary ports or a sectoralization. That means on the same side, on the left side, 2 secondary ports on the left side and 1 umbilical port or supraumbilical port, that is a primary telescopic port. So the diagnostic laparoscopy is the first step where that is going to be done. Once it is done, our step is to disconnect the lateral ligaments. Usually the right side and left side will be done one by one with the help of a vessel sealer or a bipolar energy or with the harmonic scalpel. All these 3 important pedicles, important structures like the ovarian ligament, fallopian tube, and as well as the round ligament on the right side and left side are being dissected here. So the technique is very simple, that you need to cauterize between the 2 points and cut. Here the vessel sealer is going to be used. This is a modified vessel sealer where it is going to cauterize, and as well as with the tip it is going to cut. That is very, very important. And you have to go towards the uterus and a space is created. So under vision you have to do it very clearly, so that the uterus is going to be freely floating in the peritoneal cavity. These 3 structures are very, very important to disconnect totally. When the 3 structures are disconnected, then go to the creation of the bladder, urinary bladder flap. Here the right side monopolar, bipolar vessel sealer is being used. On the left side the regular bipolar is going to be used. So some of the surgeons, they prefer left side, right side, both the energy sources, and gradually that you will dissect the entire uterus towards the urinary bladder. Now you can see gradually it is going towards the urinary bladder. Then slowly the space is being created, and this fold is the bladder fold. Always remember, when you are making a TLH case, try to select a small uterus by ultrasound and as well as a thin patient, and that should be always your first case, so that you will be more concentrated. You will be concentrating more on each structure what you are dissecting in the pelvis. So now the peritoneum is being dissected here, and that is the bladder. Always remember that your dissection should be towards the cervix. Towards the cervix. So this is a case where it is a fairly a fresh case, so that there won't be any additions. But some of the cases there may be a lot of additions because of the previous cesarean sections. So in those cases it is difficult, but you have to use the scissors. I prefer scissors by cutting towards the cervix. If you leave a little cervix towards cervix, if you dissect towards cervix, that is always better than going towards the bladder. If at all, sometimes there may be injury to the urinary bladder, nothing to panic about that, and you can suture it in 2 layers with Vicryl, and keep the Foley's catheter for about 7 to 10 days. That is enough. Now the uterine arteries are being cauterized at 2 points, medially, laterally, and cut in between. Remember, in any laparoscopic surgery, when you cauterize 1 centimeter, always cut half centimeter. That is the secret of no bleeding at all during the surgery. So if you cauterize in that manner, and bipolar, you see that there are a lot of bubbles are coming, and you have to cauterize till the bubbles are stopped. You can see the uterine artery is being dissected here. This uterine artery can be dissected with the bipolar, monopolar, or harmonic also, and you may manage that with a suture or with a clip or with simple vessel sealer. That is quite sufficient. Now going towards the lateral angles. Now the vaginal wall is going to be open now. So some of the people, they put the cup inside so that they can cut circularly with a hook, or some of the surgeons, they just simply withdraw that area if there is a good descent, and the lateral angle is going to be dissected so that the vaginal cavity is going to be open laterally. That is very important. So after uterosacral management, that means you disconnect them, then gradually go ahead laterally so that you can open the vaginal cavity. Then when you cauterize the uterine arteries on the both sides, the next step is to put a cup inside of the vaginal cavity so that you can cut on the basis of the edge of the cup. In the market, there are different modifications of the cups are available. If there is a good descent, you can also sometimes put a Mayama screw so that you can just retract the fundus of the uterus and simply go ahead with all the steps of the TLH. So usually the bleeding is one of the problem, and there may be injury to the urinary bladder, or sometimes there may be injury to the sigmoid colon or the rectum or the small intestine. Nothing to be panicky if at all they get injured. This is very important to notice the injury first. If you have noticed it, then you can repair it. So sometimes during the dissection at the broad ligament or Meccan rods, then there is a chance that you may injure the ureter also. So that ureter injury, you can deal it by yourself, or you can take the help of a urologist. So TLH may include preserving the fallopian tube with ovary, or you can take them out also along with that. See, the cauterization should be like that, 1 centimeter of the cauterization and half centimeter of the cut. That is very, very important. Now gradually the vaginal cavity is being opened here. See that there is no bleeding. Take your own time and cut small bits. Then the vaginal cavity is being opened here. So gradually you can see the cervix here, and circumferentially the vaginal wall is being opened up. See, there is no bleeding. If at all any bleeding, immediately just cauterize it. That is very, very important. The complete cervix should be seen, and that should come out with the specimen. So either you can do with the sectoralization or the triangulation. The entire specimen is being manipulated with these angles. Now you can see the entire TLH is being done and the specimen is being taken out, retrieved through the vaginal cavity. Then the vaginal vault is being repaired, sutured with either a barbed suture or vicryl or the proline. Usually I use barbed suture. And that finishes the procedure of total laparoscopic hysterectomy. And thanks for watching my video. Keep on watching more.